for the introduction, and also thank you to the organizers for inviting me here to beautiful Puebla to this great meeting. My task today will be to talk about the pathophysiology-based treatment of irritable bowel syndrome. So when you read recommendation about how to treat patients with irritable bowel syndrome, you will often find suggestions like this to use kind of a stepwise approach to offer safe diagnosis, explanation, reassurance to all patients, and then based on the symptom pattern or symptom severity, you add other layers of treatments, such as dietary advice, pharmacotherapy, psychological treatments, options, and so forth. And ideally, when you recommend a treatment for a disease or disorder, you should base that on a thorough knowledge of the pathophysiology. And as you know, for IBS, we do not have 100% knowledge about the pathophysiology. So this approach is not straightforward when it comes to IBS. But I will try to convince you during my talk that actually we have a lot of pathophysiology-based treatment options in IBS, regardless of or despite the fact that we don't know everything about the pathophysiology until today. So I would like to start off with one of the most well-known pathophysiological factors in IBS, and also one of the most well-studied factors in pathophysiology of IBS, that is gastrointestinal dysmotility. Unfortunately, we do not have a specific motor abnormality in IBS, but what is a little bit more consistent in the literature is that we can see transit abnormalities in at least a subset of IBS patients. You can say that this is the result of abnormal motility. And if you look at the transit in patients with IBS and you try to link that with symptoms, the abnormalities that you see in colonic transit and transit throughout the GI tract is mainly linked to the abnormal bowel habit of the patients, whereas it's not associated with pain and bloating to the same extent. So if you want to change bowel habits and improve bowel habits in IBS, affecting colonic transit seems to be a valid target. And there are actually several studies that have demonstrated that if you can pharmacologically alter transit in patients with patients or not in healthy individuals, you can actually change the bowel habit. This is an old classical study where they looked at this concept. They used senna and loperamide, and they measured transit and also bowel habits. And as you can see, with senna, they accelerated colonic transit, and with loperamide, they retarded colonic transit. And if you looked at the association between the change in transit and the change in bowel habit, there was a clear association between the change in bowel habit and the change in transit. So this actually highlights the fact that if you want to improve or change bowel habits, you can actually target transit, which was demonstrated in this study quite nicely. There are more recent examples along the same lines. Linaclotide is, as you know, one of the new players on the block here, kids on the block, one of the new players in the IBS treatment, among new IBS treatments. This is an agonist of the guanylate cyclase C receptor, and by agonizing this receptor, it increases secretion into the GI tract. And by increasing secretion, it stimulates motility. And here's a transit study from Michael Camilleri's group where it was demonstrated that linaclotide accelerates transit in the colon. It improves the emptying from the ascending colon. So this was a clear demonstration that linaclotide affects colonic transit. And theoretically then, it should also then improve bowel habits. And this was, as you can see, demonstrated in this pivotal trial where they looked at patients with constipation predominant IBS, used linaclotide. What you can see is that with linaclotide, there was an improvement in bowel habits, increased the number of complete spontaneous bowel movements. In the left side of this line, you see the short trial, the 12 weeks trial, and in the right side, you see the longer trial, 26 weeks. You can also see something that's quite characteristic with the effect of linaclotide. You can see a rapid effect in the effect of bowel habits. So by affecting the colonic transit, they could definitely improve bowel habits in these patients, in supporting what we said previously. There are also similar data with the other secretagogue drug, namely lubiprostol, which also affects transit, and by doing that also affects bowel habits. One of the most important players when it comes to motor function in the GI tract, one of the most important molecules involved in motor function is serotonin, and that has been stimulated quite a lot in IBS and other disease states. And serotonin in general stimulates motility in the GI tract. And if you look at the studies that have been performed so far in IBS, this slide quite nicely summarized the main findings. That you can see that serotonin is actually upregulated in diarrhea-predominant IBS, and if anything, downregulated in constipation-predominant IBS. So there has been a lot of drug development regarding affecting the different serotonin receptors in IBS, and I will show you some example of this. And also again, this goes back to the effect on transit, affecting bowel habits. Here's one of the older studies when it comes to drug development regarding serotonin in IBS. This is allosterone, which is a 5-HT3 antagonist. And as you can see on the left side here, it can actually slow down colonic transit in patients with diarrhea-predominant IBS. And by doing this, it can improve stool frequency, can reduce stool frequency in patients with IBS-D, and also improve stool consistency. So again, evidence showing that affecting transit is clearly something that you can use to affect the bowel habits. The opposite is true for this one, procalcipine, where you can actually, which is a 5-HT4 receptor agonist, where you can, with this drug, you can accelerate colonic transit, and by doing that in patients with constipation-predominant IBS, you can increase the number of bowel habits, the number of stools, and improve the bowel habits in these severely constipated patients. So another line of evidence linking transit, effect on transit, and affecting bowel habits. So one of the other main pathophysiological factors in IBS is, as you know, visual hypersensitivity. And when you look at the link between rectal and or visual hypersensitivity and symptoms in IBS, the strongest link is between presence of hypersensitivity and pain, which we demonstrated in this study that we did a couple of years ago, where patients who reported hypersensitivity were more likely to report more severe pain and bloating. So theoretically then, if you affect hypersensitivity, you should be more likely to affect symptoms, pain and bloating, compared to some other symptoms in IBS. When we try to treat pain in the clinical setting, we often use antidepressants, and there are a number of effects through which antidepressants can affect symptoms in IBS, and they are highlighted here. And I would like to focus on the next slide on the effect on visual analgesia, because there are some studies that have actually demonstrated an effect on visual hypersensitivity and in IBS patients, and in parallel improvement in pain. And one of these examples is this study from a Canadian group where they had treated patients with a tricyclic antidepressant, amitriptyline. They measured the pain thresholds before and after the treatment period, and also the evolution of gastrointestinal symptoms. And as you can see here, the pain threshold went up. That it means that the patients were less sensitive after amitriptyline. And here you can see that the symptoms improved. And if you can see here, they tried to plot the change in rectal sensitivity versus the change in GI symptom severity, and found a quite nice correlation. This is a small study, but still some of the evidence, one of the lines of evidence suggesting that by affecting visual hypersensitivity, you can improve pain in patients with IBS. Coming back to linaclotide, which, as I said previously, is an agonist of the guanylate cyclase C receptor. There are some evidence also suggesting that linaclotide actually can reduce nociception, at least from animal studies. This is a very nice study that was published a couple of years ago in gastroenterology, where they looked at mechanosensitivity. They stimulated the gut mechanically and measured the colonic nociception, and what they could show was that linaclotide inhibits colonic nociception, and that was particularly true in animals with chronic visual hypersensitivity. And it also reduces the processing of noxious colorectal distension in the spinal cord, providing evidence that actually linaclotide can reduce nociception. So in the clinical setting then, this should be translated to less pain in patients with IBS. And if you again look at the pivotal trial, there are actually evidence suggesting that this is true. So you can see here that the linaclotide compared to placebo had a great effect of the abdominal pain in using this endpoint. but I would like to highlight something else that is quite clinically important. You remember the slide that I showed you previously with the effect on bowel habits, which comes during the first week, whereas here you can see that the effect on abdominal pain comes gradually and can actually improve over several weeks, which is something that you should bear in mind when you treat your patients with the macrotide. So now I will move over to another perhaps more recent line of evidence of the pathophysiological research in IBS. That is that there seems to be some kind of abnormality in what we can call the mucosal crosstalk in IBS. There are several factors involved in this, and we heard already about the gut microbiota, which of course are important players in the mucosal crosstalk, but there are also, of course, immune function, barrier function, and also luminal factors such as bile acids and food. And many of these have been implicated in trying to find new treatment options for IBS. Some of them successful, some of them less successful. I will show you some of them, some of the drugs, some of the treatment options that we can use today, and something that might be relevant in the future. And I would like to start with immune function, which has, there are, as you know, several studies that have demonstrated a slight upregulation of the immune activity in patients with IBS. And therefore, it has been tested whether anti-inflammatory treatments can be used for patients with IBS. There were some small studies with methalasine in IBS patients which showed some quite promising results. So therefore it was a little bit disappointing when this study and another study came out in gut back-to-back. One study from Giovanni Barbara in Italy, the other study by Robin Spiller in Nottingham, UK. Both actually negative studies when it comes to methalasine in IBS patients, even though there was some secondary analysis that were positive. But at this stage, I don't think we can say that we can use methalasine in IBS. We don't have any clear evidence that we can use methalasine to treat patients with IBS. But maybe in the future we can try to identify those who respond and see whether we can actually personalize the treatment a little bit more, maybe use some kind of immune activation marker to see whether we can actually predict who will respond to this treatment. But at this stage, methalasine cannot be recommended to use for IBS. But I think there are some other options when it comes to reducing immune activity that is worth exploring. One factor that is often neglected when it comes to patients with IBS is the role of bile acids, but there are some more recent studies that have looked at the role of bile acid in patients with IBS, especially in those with diarrhea. Bile acids then escaping the reabsorption in the last part of the small intestine, entering the colon, stimulating secretion and motility, leading to diarrhea and loose stools. This is from one of our studies where we looked at a mixed group of IBS patients and measured bile acid loss into the colon with the CCAT, there we go. With the CCAT test, which actually measures how effective this enterohepatic circulation is. And with a low value indicates that you lose bile acid in the colon. And actually 18% of the IBS patients had an abnormally low CCAT test indicative of bile acid diarrhea. We treated them open label with cholesterol, one of the bile acid binding agents, with quite good results. And there are also other studies that have demonstrated that bile acid binding agents can be actually used quite effectively to treat patients with IBS with diarrhea predominance, something that to keep in mind in your clinical practice. We heard already about gut microbiota, so I will not talk too much about that, just a few words when it comes to treatment. As you know, there are a lot of studies, Professor Werner showed you some of them, that have actually demonstrated that gut microbiota seems to be altered in at least a subset of IBS patients. These are two other studies that have actually come up to more or less the same conclusion, that there is a subset of IBS patients with abnormal gut microbiota, but also a large group of patients with IBS who have a normal gut microbiota composition. But it seems logical then to try to modulate the gut microbiota in some sense to improve the symptoms in IBS patients. And as you know, one of the treatments that have been using this principle is rifaximin, the non-absorbable antibiotic that is available in several countries around the globe. And this is from the pivotal trials assessing the effect of rifaximin versus placebo. They treated the patients during 2 weeks with rifaximin or placebo, and then followed the response over 12 weeks. You can see that the patients who received rifaximin did better than the placebo group, but you also see that the effect, the superiority of the placebo is quite small, and you also see that the effect gradually disappears if you don't use the drug repeatedly. So this is a promising treatment agent, but I think we still need to know more about why some patients respond and others do not. So we need to find predictors, and probably also learn more who to give this treatment to in the future. Food is, as you know, something that is very central to IBS patients. Many of them complain about food exacerbating their symptoms or increasing the symptom severity. And there are several studies using different questionnaire methods that have actually come up to more or less the same conclusion, that the majority of IBS patients seem to find a link between food intake and symptoms. And we can also show that here is a standard Swedish breakfast. This is what we eat every day in Sweden. Oatmeal porridge, hard bread, milk and apple juice. This is not really true, but this is what we serve our patients in the laboratory anyway. And we call it a standardized Swedish breakfast. And you can clearly see, without going into details, that the patients report much more symptoms with higher severity compared to the health controls. So food seems to exacerbate or worsen symptoms in IBS. So therefore it's quite logical that we now try to modulate the diet in some way to improve symptoms in IBS. The most popular approach today is the so-called low FODMAP diet, which we've heard already about a little bit, the fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, which are poorly absorbed carbohydrates, which pass down into the colon, and in the colon they meet bacteria, which leads to gas production, and also through osmosis, these carbohydrates drag water into the lumen, and this leads to distension, and in a susceptible individual, this can lead to symptoms. And compared to a traditional diet, or not to a traditional, not to a standard diet, or if you continue with your diet as unchanged, or if you eat, in this case, an atypical Australian diet, you actually can reduce the symptoms by reducing the FODMAP content in your food. But it's not so clear whether this is actually better to give the patients advice of following a low FODMAP diet compared to what we can consider traditional IBS dietary advice as recommended by NICE in the UK, to eat small frequent meals, to peel and divide food into pieces, chew thoroughly, boil food rather than fry, reduce fatty and spicy food, legumes, onions, coffee and alcohol, avoid carbonated beverage and artificial sweeteners, and if you should continue the fiber intake, but you could divide it evenly over the day. So we did a trial where we actually randomized the patients to a low FODMAP diet, or what we can call traditional IBS dietary advice. And to the left you see the primary endpoint in our trial, which was published 2 years ago. As you can see, the responder rate was more or less the same in both groups. Roughly 50% of the patients responded to each treatment arm. And if you do, and there was another study from the US, they used a similar approach for the traditional dietary advice. They call it the modified NICE diet. And also here, there was no significant difference when it comes to the primary endpoint. There were some secondary endpoints that were positive in this trial, but the primary endpoint was not positive. So I think this tells us that the low FODMAP diet is not the holy grail. This certainly helps certain patients, but not all of them. And we should probably start with the most simple one, simple advice, the traditional dietary advice first, and probably reserve the low FODMAP diet for those who don't respond. And we should probably also be very careful to not only leave the patient in the exclusion phase, where we exclude all the high FODMAP food. We should also be very careful to help them to reintroduce food in the long run. My last couple of slides will focus on the gut-brain axis, and because, as we showed in this study, when it comes to food response in IBS, it's not only what happens in the gut, probably also other factors are of importance. In this study, we looked at the relevance of psychological factors for the postprandial symptom response. We again used this famous standardized Swedish breakfast. We followed symptoms, in this case bloating, over 4 hours. And we divided the patients based on their anxiety severity and also based on the severity of somatization. And with increasing levels of anxiety, the symptom response was higher in patients with IBS after this meal intake. And with somatization, there was also an exaggeration in the postprandial symptom response. Turning our eyes into what you can call the gut-brain axis, which is of high relevance in patients with IBS, which we believe that this is mainly explains a large part of the symptoms in patients with IBS, that there is an abnormal interaction between what happens in the gut and what happens in the brain, with peripheral factors probably dominating in some patients, whereas more central factors may dominate in other patients. So this turns our eyes into the role of treatments targeting the central nervous systems, and there are several lines of evidence suggesting that psychological treatments are of importance for patients with IBS, and there are numerous studies that have demonstrated that these are effective. This is from a meta-analysis from Alex Ford, and you can see up here for all these different psychological treatment options: cognitive behavioral therapy, relaxation, hypnotherapy, and dynamic psychotherapy. There seems to be an effect of these treatment options, with a quite reasonable number needed to treat for these options. The problem is availability of these treatment options, but they are effective. I think we can say that from the literature. And also when it comes to use of antidepressants, also quite impressive number needed to treat for tricyclic antidepressant and SSRIs. And these are also some drugs that we definitely can use in the clinical setting for patients with IBS. So I hope that I convince you that by learning more about the link between pathophysiology and symptoms in patients with IBS, we can improve our interventions for these patients, and this hopefully then will lead to improved health, better quality of life, and reduced costs for our patients. Thank you very much for your attention.